great to have the invitation to come and talk to you. Just a bit about myself, as Heinz says, I'm an ophthalmologist. I'm a Kiwi. I trained in Dunedin and Christchurch and then did my ophthalmology training in the UK. Came back and worked in Northland initially, and I guess that's where I got an interest in health inequality and started really getting on board with every committee I could that maybe had an influence on how we provided healthcare in New Zealand, and somehow I've ended up chairing the Council of Medical Colleges. I sometimes wonder how, but the council, I think in the past, has been criticised as being a bit of a talk fest, but I think the last 4 or 5 years, I think we've moved it forward into being a little bit more, as Heinz says, a bit more proactive and getting involved more in issues. It's essentially a membership organisation of about 15 colleges at the moment, so it's indirectly representing about or over 14,000 doctors, vocationally trained doctors, including GPs. It's obviously a collective voice for the colleges, although it can't speak, the colleges have their individual views on a lot of topics. Obviously our interests are the same as interests as the colleges, so interests around vocational training, professional development, promoting professionalism and advocacy around the health sector. And actually I was interested in that last question, and just make a comment, Hein, that you were being, as I was coming in the taxi, they were quoting your comments about under-resourcing of the health system, which is particularly pertinent to ophthalmology at the moment, so I've got a keen interest in that. With regard to this talk, obviously we're a conduit for information going backwards and forwards between Health Workforce New Zealand and the colleges. Now, I realised when Ian gave me this talk, once I started to sit down and do it, that this topic, should I say, that it's just painfully boring topic. So what I'm going to try and do is actually get through a little bit of a brief description of how we got to where we are, some of the proposals that Health Workforce New Zealand have come up with in the last few years, and then try and leave plenty of time for a bit of discussion around this, because I know that all of you will be working in DHBs and have be interacting with trainees who are involved in training and probably have some really good insights into the problems in the present system and also ideas about these proposals. So, you all know that essentially medical training is divided into these three parts. The undergraduate training through the universities, pre-vocational is essentially run by Medical Council, or by the DHBs on behalf of the Medical Council. And then vocational training, is essentially determined by the Medical Council, but performed by the colleges on their behalf. How do the colleges get involved with this? The colleges go back to sort of medieval Europe and the craft guilds, and then obviously in New Zealand we had colleges starting to be set up really from the 1920s onwards. So the medical schools were going in Otago, the late 1890s, but specialist training didn't really happen in New Zealand until the late 70s or the 1970s on a regular basis. And in fact, the Medical Council only had a register of specialists after the 1968 Act. Some of the colleges were binational from the start, so RACS, for instance, was Australia and New Zealand from the 1920s, but others have become binational as a lot of the requirements have become more stringent around training and qualifications. But there are some that, so of our membership, 10 colleges are binational and the others are New Zealand only. If you look at what's happened over the last few years, you've got new colleges developing as new specialties have developed. We've got new craft groups within the larger colleges, again with subspecialisation. And you've got increasing requirements from the Australian Medical Council and the Medical Council of New Zealand through their accreditation standards and the MOUs between the Medical Council and the colleges. We still have, even though we are training our own, we still have a high reliance, as you know, on overseas trained vocationally registered doctors. And I think it's interesting in that setting that despite the fact we've known for 15 years that we're going to have this big increased cohort of medical graduates, that there's really been little or no planning or funding for vocational training of those new grads as they come through, and as you know, they're flowing through PGY 1 and 2 at the moment, but there really hasn't been any extra resource put into vocational training to meet that group coming through. So how's it funded at the moment? So Health Workforce New Zealand has contracts with mainly DHBs for training. The trainees essentially have a subsidy allocated to them to recompense the DHBs for any slowdown or the training component of them being employed by the DHBs. And the amount is different for every specialty, and it's based on a historic formula that no one can quite remember how it was derived, although there might be someone in the audience that was involved, I don't know. But so, for instance, a gastroenterology trainee will get $62,000 a year from Health Workforce New Zealand, whereas anaesthetics trainee $42,000, and presumably that somehow reflects different service contributions from different trainees. The only difference to that, and the other thing is to say, and I'll give you the numbers in a moment, only about 2/3 of trainees actually receive Health Workforce New Zealand funding. The others are completely funded by DHBs. General practice, the contract's now actually with the College of GPs. So just in dollar terms, the amount for medical vocational training is about 62 million. And the numbers down there, so of the 1,730 trainees last year in New Zealand, only 1,146 actually had Health Workforce New Zealand funding. Health Workforce New Zealand train a whole lot of other health professionals, and they would like to be probably putting more money into some of those other groups, in particular in the unregulated or kaifina workforce. So what are the problems with this system, and why is Health Workforce New Zealand looking at changing the way we fund training? Well, firstly, the colleges certainly have some issues about the way it's funded, and agree in principle with Health Workforce New Zealand that probably the system is not wonderful. The actual money being spent doesn't really match up with the actual training costs. The funding goes straight to DHB, so it's not linked to the trainees, so it's really seen as just another funding stream by DHBs, and so it means they don't have any really direct responsibility for training. The number of training positions is very loosely based on future needs. Some colleges have quite good workforce data and try and influence the number of training positions carefully to make sure that their trainees actually can come out and have a job at the other end. But a lot of specialties, the number of trainees is largely determined by the service requirements of the DHBs, so it isn't really based on any sort of future planning at all. And as mentioned before, the other criticism has been that there hasn't been any increase in funding to meet the increasing number of graduates coming out. Health Workforce New Zealand probably have similar concerns, but they also are particularly bothered by the fact they really don't have any levers to control training numbers or what specialties are being trained. They're also bothered by the fact that there's quite a bias towards medical vocational training, training in hospital settings, and they would like to be able to target where they're investing their money. And I think they also probably are quite fairly critical of DHBs in that they feel the DHBs really, if they're trying to meet the New Zealand Health Strategy goals, that they should actually be taking a keener interest in training an appropriate workforce. And if you look at most DHB annual plans, there's virtually nothing, if anything, about training in their annual plans. So there are a few other areas in healthcare where we have problems that perhaps another funding or training model might be helpful. So we've got shortages in some specialties. We've got small subspecialties that have vulnerable workforces where maybe a regional or national approach might be better than the current model. we've got problems with maldistribution of our SMO workforce and our GPs, and we've also got other inequalities in healthcare delivery. So Health Workforce New Zealand have been around for about 7 years. They replaced the CTA, but with a slightly broader brief. It's chaired by Prof. Des Gorman, and I just sort of run through a few things they've done. I think I realised when I was putting this together that we've had quite a few different approaches from them over the last few years. So I'll just run through where they've come from and where they're sort of possibly heading. So initially when they came in, they were very resistant to having any sort of health workforce plan. I think the colleges liked the model that Australia was taking, where they were actually getting some really good data together, trying to look at their future needs and try and match their trainee numbers with future needs. And possibly here, because there wasn't very good data, the Health Workforce New Zealand approach was, that's actually impossible. You'll never know what you want. We just need to train a flexible workforce that can respond to the kind of future needs. So we found that a little bit frustrating. At the same time that we were discussing this, they were doing a review of specialities where they were promoting different models of care and working with the ministry to really remove barriers to role substitution. So you'll be aware of the work to remove or replace the word doctor with health professional in all the acts, the changes to the Therapeutics Act and things like this, really, which they were using to try and make it easier to develop new models of care. I'll get back to models of care in a minute. They also started working with the colleges a bit later to try and work out how to identify what were the vulnerable, or they talked about vulnerability and criticality of specialties. And they came up with a number of different ways of trying to look at this, looking at the age distribution of SMOs, the dependence on general registrants, dependence on IMGs, and what contribution each specialty was making to the government priorities. But initially, when they tried to do this, that kind of fell over, and then they asked the colleges to do it, and the colleges really struggled with this as well, because these are actually big questions. How do you compare doing in my specialty, a cataract operation versus, say, paediatric mental health, services? It's a really tough thing to prioritise. Following on from that, they did actually start getting a bit of better data, and really this came about because of the move of the APC process to being digital, because suddenly we started just mindlessly filling in the form rather than ignoring those last 3 pages. Everybody started actually clicking and putting down information, and suddenly there was a bit of workforce data that Health Workforce New Zealand could use. So they're now producing quite a useful report, the Health Workforce Report, and they've also come up with this Health Workforce Calculator, which allows them to have a look at what trainee numbers we need for different future workforce requirements. Having said that, they also are still bothered by the lack of any levers to control the present system. One of the things the colleges have, I think, done successfully with Health Workforce New Zealand has been to try and develop some better career information for medical students and RMOs, and I think that's work that actually has been very useful and we would like to carry on and probably improve on. Really, it could be done better. So in terms of moving towards a new funding model, there's been a lot of workshops talking about the kind of principles around this, and I won't go through them because most of them are kind of motherhood and apple pie, really. And then following on from this, actually might flick past that one actually. So following on from that, they've started to come up with some ideas around how they could change the funding model. So one has been basically the status quo, subsidising trainees, but top slicing off some of that money, so providing less subsidy, and that creating a pool of money to target at problem areas, so areas of shortage. One of the difficulties, or one of the things that will be a recurring theme as we talk about this, is that they basically, that 62 million they believe is their funding, and that they can't get any more money than that. So they're looking at a system to somehow do more, but with no more money. So another one might be, and one of their other ideas was to move the subsidy from being attached to training positions or training sites and actually have that linked to the trainee. And another idea was to reduce the subsidy and actually use some of that surplus to kind of invest in the infrastructure of training. And so in general practice, that might be actually building another room on a general practice so you can have a trainee at that site. Now, while they were talking about these ideas, and this was really until middle of this year, they were only talking about the medical workforce that they were applying this to. I think the problem is, as we talked about before, models of care, is that hovering over this whole debate has been, it's very hard to predict what workforce you need if you don't really know the model of care you're going to be using. If you're going to be using a clinical nurse specialist providing a lot of care in a particular service area, then you're going to need a lot fewer vocationally trained doctors. So I think this has been a problem that Health Workforce New Zealand keep butting up against. And so just recently they've come up with a slightly more radical solution. And this, it'd be fair to say, as I comment about this, that this is only partly formed and we don't have a lot of information about it, and so it's been quite hard to really have a strong view about where this is going, but I think it's useful to talk about the idea. I've called it rather cynically the Grand Unified Theory because I used to be a physics geek before I did medicine, and they've been trying to sort out the Grand Unified Theory for 40 years and haven't got anywhere. But so the idea of this is that you actually basically incorporate the whole discussion around models of care and workforce and look at it as a whole. So rather than the current situation where we train a whole lot of health professionals and then as we have discussions around model of care, we kind of try and fit them into the model, the idea of this would be is that you actually look at the model of care and then you train your workforce to fit that. It's kind of great in theory and at an intellectual level it's quite appealing. From a practical point of view, they're talking about a sort of a Farm Act type approach, so having a central agency that you put bids into for essentially a clinical pathway almost, and that the bid might be put in by a consortium that might include patient groups, health providers, training agencies, and then this will be sort of evaluated by an expert advisory group, and the training component of that will be assessed for its return on investment. So, and that's return on investment in the broadest sort of way of looking at it. So not only how much it costs to train, but the cost of that health professional in their working career and the actual health benefits you get from that. So it's a pretty big, it's sort of a pretty big concept. I think, to be fair to Health Workforce New Zealand, they see this being transitioned and gradually starting off perhaps with looking at each service and each health workforce requirement and sort of scoring this on and then gradually moving towards a more pure bidding kind of process. And obviously you can see the benefits of it. You get a better match of workers to service needs. You're able to modify models of care to give better geographic distribution of services, and your services are more aligned with a health strategy. I think there are a lot of risks here, though. It's a pretty complex concept, and you just sort of feel that there could be a certain amount of paralysis of trying to get something like this going. You also wonder whether you'll end up with, rather than a more flexible workforce that's so targeted to these models of care that down the track they will have less of a role or won't be able to be used in other areas. And you potentially, I think, you're also looking at developing a whole lot of new qualifications that may not actually be recognised outside of New Zealand. And I think the impact on the medical workforce has to be considered quite carefully as you look at models of care that may work great in an urban area but actually destabilise the whole way we provide care in provincial areas. And I guess the cynical side of me, and probably following on from Ian and Hein's earlier comments, worries that this is about really looking for the cheapest solutions to our healthcare rather than necessarily the best quality solutions. So I think, just summarising so we can get on and maybe just have a bit of discussion about this, I think the present system has produced high quality health professionals, but clearly we've got some problems with undersupply, maldistribution, lack of diversity, and shortages in some specialties, and perhaps the health professionals we're producing are not ideally suited to some of the newer models of care. So I think that's absolutely true. We need to be aware that vocational training in medicine takes a long time. There's a big investment by people going into it and also those providing the training, and remembering that a lot of the training is essentially done pro bono by SMOs. So whatever changes we have to health funding, we don't want it to be undermining the careers of people going through that process at the moment, all their training. I think this new model has certainly got some positive things about it, but I think there are some risks. I think the college's views at the moment are that this is very early on in this proposal, and that at the moment they just don't have enough information to have a clear response to it. I think we all agree that the present system has its weaknesses, although a lot of the colleges would say perhaps if you fully invested and actually funded it and then looked at some of the problem areas and look at how you could incentivise training in those areas, that you may actually achieve just as much as a radical rethink of the system. It's an interesting point talking here about areas of shortage, because Health Workforce New Zealand's idea is that you can solve that by incentivised training in those areas, but the obvious question is, if people don't want to work in palliative care, maybe it's something to do with the SMO conditions as much as it is to the training system. Which is the thing I just forgot to say. If you go back to this, just to maybe explain the practicalities of what they're suggesting, if you look at an area like palliative care, if you looked at this return on investment model, you'd actually look at that whole service. You might decide that actually there is great value from having more palliative care specialists, so you'd have a bid for 3 more training positions. But what Health Workforce New Zealand would say is, because their funding's fixed, they would then have to look at disinvesting in another area, say general surgery, and they'd reduce their subsidy into that specialty. But the other thing is they might actually look at palliative care and say, well, we don't think that the whole specialist model is actually the right model for this. We'd actually rather invest money. We think it'd be better to put this into nurse specialist palliative care services in primary care, or the unregulated workforce or Kaiwhina workforce. So that's very much open to, they're talking about a very open system where there could be quite radical changes in the way you actually provide healthcare and who you train to do that, provide those services. So look, that's all I'm going to say, but we've obviously got plenty of time for questions, and I'm really interested in your thoughts about both the present system and the problems of it, and also where you see some of these ideas from Health Workforce New Zealand going. Thank you.